Good evening, everybody. Welcome to 2026, the Whole Again webinars. I hope all of you had a very restful December, not too eventful. And maybe some of you can put on the chat group where you've been. We're looking for interesting destinations for our family next year. And I'll tell you a little bit about mine in the course of the talk. So we're starting off the year, so we're going to have about 10 or 11 webinars. From some of your suggestions last year, we've already chosen most of the topics for the year, and Leonie will advertise it. If we need to change a topic or two along the way, as long as it's an academic topic, we won't mind, and we obviously need to try and keep it in the longevity space and hormonal space. So let's start today. We're going to be starting off with case studies this year, just to freshen things up and remind some of you about some of the basics things we all see in our day-to-day practices. Whole Again's excited because we've got a whole new range of products coming out. There's about 11 of them. There's a fantastic product range from a probiotic perspective. So currently, the best combination probiotic currently on the market would be the Solal Probiotic Maximum. It's got some probiotics, but it's got a prebiotic and digestive enzyme. And historically, I was involved in the design of that 25 years ago. At the time, you could only fit in maximum of 16 billion. There's a bit of a typo error here, but you can see the new one coming out will have 34 billion, 17 billion per capsule, and with some very interesting yeasts, wild yeast, with a higher dose of FOS as a fiber prebiotic, and then a higher dose of digestive enzyme as well. A nice combination product to maintain good gut health. And then we've got a 250 billion with a different range of species compared to what's been available in the past. There's a 550 billion, and then there's a trillion as well. And mainly because currently in South Africa, the highest dose available was the Vivo Mix, 112 billion in a capsule. And the sachets, 450 billion. It's been reformulated, and they added a bit more, 460, which by and large for many patients will be enough. But the kind of patients I get, we definitely needed higher doses. And so that's now coming soon. And then the very exciting one, Gut Therapeutics Lean. This one has quite a few species of bacteria that have been known to improve metabolic conditions, weight, fatty liver, blood pressure, insulin resistance. And so it's got Akkermansia, currently the highest in the world. So the data was published on Akkermansia 60 billion. This one's got 30 billion. And the reason why it's higher is this entire range of probiotics and digestive enzymes are coming in a capsule that is acid retardant. In other words, none of them die in the stomach. So from published work, about 70 to 93% of probiotics that you consume orally will unfortunately die in the stomach because of the acids, and basically about 10 to 30% will trickle through. And that's why with patients with severe leaky gut dysbiosis, we use very high doses to try and get as much as possible. Now, with these capsules, the entire amount is going to get through. So if you look at the lean, where it's got 30 billion, and the study was done on 60 billion, remember, only 10 to 30% of that 60 billion got through because those were normal capsules. This one has extremely high levels. And then there's one, I've mentioned it last year, that in the field of the microbiome, they've identified lack of certain bacteria to be causing allergy states and asthma. And so there's one of those coming up. Enzymes, much higher doses of enzymes, but more importantly, a whole lot of other added products to help with digestion of the gut. And then there's Gut Nourish, a product with 7 different fibers, all designed to assist in allowing good bacteria to survive. Then there's one called Gut Shield with high doses of glutamine and curcumin, which helps the inflammation of the gut. Remember, the biggest issue with leaky gut or any of the irritable bowel diseases is that there's inflammation of that single layer, and that's what we need to improve. Then there's glucose balance. There's one for prostate. There's a hair, nail, and skin product called Hair Glow. I think it comes out this week, tomorrow. And then there's Oil Mega, which I've been looking forward for a long time. This is vegan friendly, sourced from sustainable sources. The DHA is 400 and the EPA is 200. So the first time you got a beautiful ratio, but also the highest DHA currently available on the international market in a sustainable, heavy metal, toxin-free and microbe-free product. So that's what we've got to look forward to this year. More importantly, these bacteria are not only higher in number, they are also in the capsule that I mentioned, that keeps all of them alive until they get into the intestines. And then all of them have some spore-producing bacteria as well, so they can self-propagate. So that's what we're looking forward to. These are my disclosures. I speak on behalf of various companies and have invested in quite a few. This is for you guys to get your CPD points. So if you watch it live, you get 2 CPD points per webinar. Of course, some of these recordings are available that you can watch in your own time. But then, of course, you're not going to be able to get the CPD points. Communicate with Leonie, and she'll get the CPD points to you. This does take a while, so maybe don't rush her. Give us some time, and the delays are because of the SPC SA, HSPC SA. So let's start. So the first topic we're going to try and tackle is hypercholesterolemia, a state where the client has too much cholesterol, and so the term is lipogram. The lipogram constitutes total cholesterol. Then you've got LDL, which is the bad cholesterol, and it can be small, dense, or it can be fluffy and large. The small, dense particles are the more atherogenic ones. Then you get HDL, which is the good cholesterol. Then you get triglycerides, which is very reflective of what the client's eating. And then you get the ratios between good and bad. When you're dealing with client with a high cholesterol, the first thing you need to exclude is hypothyroidism. So a high TSH will definitely be one of the treatable causes of a high cholesterol. And so you need to sort that out. And most of the time, the patient's cholesterol levels will normalize and you don't have to treat it. But in the absence of an underactive thyroid, these are the factors that you need to be looking out for. So dietary factors, a diet high in carbohydrates will definitely affect cholesterol. Fatty liver. Remember, the liver is an organ that's important from a detoxifying perspective. The lipoproteins are cleared in the liver. They're also made by the liver. So any metabolic liver disease is going to end up affecting cholesterol. Then there's the obvious one with genetics. There's many genetic factors that play a direct role in high cholesterol. And South Africa is well known for this because of our Afrikaner population. People of certain extract have a homozygote gene that causes their cholesterol levels to be north of 10, upwards of 20. But we mustn't forget people of Gujarati extract. That's from a state of Gujarat in India. There's Lebanese people. There's a cohort in Canada. And then people of Lithuanian Jewish origin all have genes linked to high cholesterol. Dysbiosis also plays a role with high cholesterol. And then, of course, the adrenal gland. What's important is don't just take the cholesterol in isolation. It's very important to have an overall cardiovascular risk. There are 17 risk factors. I mean, we all know about the smoking and inactivity, not eating our fruits and vegetables, and being exposed to lots of micronutrients. Those are the obvious ones, but diabetes, prediabetes, insulin resistance, the cholesterol, estrogen dominance, high fibrinogen, high uric acid levels, high ferritin levels, the lipoproteins. And so there's many risk factors. And so as part of my blood test, I always include ultra-sensitive CRP that measures inflammation and cholesterol, inflammation and diabetes, inflammation and blood pressure causes a lot of problems. I also have been last 20 years in most of my patients checking lipoproteins. It's become very fashionable in the last 2-3 years. I remember speaking at the physician's update when I just qualified, and the topic they asked me to speak on was what constitutes an executive wellness check. And in that list, I had lipoproteins, lipoprotein little a, lipoprotein big A, because that's, you want lots of that. And then lipoprotein B1, which is not good, carries around the LDL molecule. And I remember the audience were rolling their eyes because they thought this was stretching it too far. But now it's become one of the mainstay things you need to assess in somebody who's high risk for cardiovascular events. What kind of treatments we have? We've got the statins. They've been around for the better part of 3 decades now. Non-statin therapies, ezetimibe, the new kids on the block, and there's quite a few different molecules, different generations of PCSK9 inhibitors. I was involved in clinical trials in that and in that. Then there's release rice. Remember, the birth of the original statins come from a lab in the Far East where, I don't know if any of you guys did microbiology, but when you're trying to grow a species, you've got these little glass trays, and that's got a medium, and the medium is the broth is dependent on what you're trying to grow. And so these scientists were trying to grow a species, and then they found that it kept dying. And you put it in culture at 36 degrees and it kept dying until one scientist said, listen, why is this thing dying? And then they took a closer look and they allowed the thing to grow a bit longer, and they found red colonies, hence the name red. The broth was yeast, a rice broth. And then when they cultured it, it was a yeast. And what they found is that the stuff that was being produced by this colony inhibited the production of the cell membranes of the bug that they was trying to grow. And then somebody clicked and said, listen, cell membrane, cholesterol particles, something's happening to cholesterol, and the rest was history. The birth of statins, and then they got concentrated, and the molecule kept changing, and then you had the different generations. You had the initial one, which was pravastatin, then lovastatin, then pravastatin, then your Zocors of this world, and then the Espivors of your world, and then finally the rosuvastatins of the world. Polycysanols, that's just a bit of history in a history lesson. Then you got polycysanols, which not shooting the lights out, but do work and help the triglycerides as well. And then you got the fibrates that are more important for triglycerides. Don't forget the importance of CoQ10. coenzyme Q10 that has been shown already in lots of work to be depleted with the statins, and the statins are known to cause myopathy. And so by and large, 85% of people will be fine, but 15% of people will have side effects. And if you take 15% of 250 million people, there's a lots of chit chat on Chat GPT and X and social media in terms of reporting those side effects. So they're real, but by and large, it's about 15% of people that will suffer with that. So let's look at a case study. We've got lots, so I'm just going to skim through it. I'm not going to go through too much of the medical details. I've just laid out all the files here in case any of you need more information. I'll try and pull the file out. So 60-year-old female. One of the issues were hypercholesterolemia with a family history. So you can see total serum cholesterol. Ideally, you want to be below 5, in a diabetic below 4.5. And here we are sitting at 7.5. Now it's made up of LDL, if you do the maths, HDL, and 1/3 of triglycerides. So you take about 0.7 there, you add it to that, you add it to that, and that's how you come with the total. So you can see LDL very high, HDL good. So it is above the 1.2 mark. But is it enough? When you look at the ratios, no, it's above 4.1. And then shit diet. So definitely eating way too much carbs. And so you follow the patient on, you tell them to try and cut down on some carbs. They have improved. The HDL is still the same. And there's been some improvement on diet with the total cholesterol. However, obviously that wasn't enough. So the client was put on one cholesterol balance, and we've got a whopping reduction down to 2.9, below the reference range. The good cholesterol went up a bit, and look what happens to the ratio. And so what's in cholesterol balance that makes it stand out compared to its peers? It's got 400 milligrams of Reddy's rice, the highest currently in the industry. There's another one with 300, and then the rest are about 100 per capsule. But it also has polycostinol, 10 milligrams, and it's got coenzyme Q10, 100. So that's what could fit into the tablet, and that's why you get 30% and plus reduction in most people. So most of the other products, I'm not going to name them by name, but got about 100. And so if you wanted to get to 400, you'd need to use 4 of them, and then you can just work out the cost of that. Then you still have to buy the coenzyme Q10, and then you still need polycostinol. So this is 71-year-old, and let me just get rid of this. Oh, God. Sorry, I got rid of the presentation instead of getting rid of you guys on the side. Okay. All right, so there we go. And so here, the client had an LDL of 4.5 and was put on cholesterol balance. And you can see it came down nicely over a period of time. The total dropped remarkably, by about 30%. That one dropped by close on to 50%. Good cholesterol, still an issue, but you can see they just managed to improve the ratio, and the ratio has gone down by 33%. And that's obviously a good result. This is Dr. Vahid's patient, 46-year-old. So when we do webinars, we do ask you guys for some cases, and then Leonie shows them to me either the day before on the day, and then we'll see which one's valid for the day's discussion. So this Dr. Vahid says a non-compliant client from a lifestyle perspective, but works in a stressful environment and a very stressful life. And the only thing the person's compliant on is cholesterol balance. And Dr. Vahid noticed that the lipogram's improving. Let's just see the dates. So here we're sitting with let's start with the LDL. Because that's the most dangerous stuff, right? So 3.2, 3.2, yeah, it wasn't done, 2.4 and 2.8. So yes, there has been an improvement. In terms of the HDL, that's a shocker. So remember, you got to choose your parent very well if you want a good HDL. And the only other thing that raises HDL significantly would be marathon running. So clinical trials have shown that if you do marathon running, it can double HDL. Of course, anything from being sedentary to running a marathon will improve it. And then, sorry, Leonie is calling me. Hi, Leonie. Hi.
We can't see the slides.
Oh, shit. That's no good. Let me end the show and I'll restart it. Thanks. Can you guys see it now? Can Leonie, you can just put your mic off and tell me if you can see it now?
Yes, we can.
Perfect. Sorry. I was trying to.
Maybe start at the beginning of Dr. Vahad.
Yeah. Okay. So Dr. Vahad's patient was non-compliant in terms of lifestyle, very stressful home and work environment. And the only thing this guy was compliant on was cholesterol balance. So I was trying to get you guys out here because you guys on the right hand side of my screen, and then I messed the whole thing up. I just pressed the cross there. So sorry about that. But here, the important thing is that if you look at the LDL, it was high and that's improved. And then we started talking about HDL. And I said, you've got to choose your parents very well if you want a good HDL. The only thing of significance that can improve HDL would be marathon running, and that's been shown to double. It's been shown to double HDL. So from that perspective, here, this guy is going to be in trouble, especially if there hasn't been a change in lifestyle. And then we know that niacin can also improve it by a little bit, by about 10-15%. And so from that perspective, we use flush-free niacin, and in the past it was easily available because with normal niacin you would flush. And so from that perspective, this is what I would suggest, that this guy have to get active. And then you're not going to win, Dr. Vahad, if this doesn't improve. I mean, here the client was at risk of pancreatitis, right? And if this person is alcoholic, then that is the kind of picture we'll see. The other thing that can cause this when they're not consuming alcohol would be underactive thyroid, so you need to exclude that. In pregnancy, we see triglycerides go up, but never this high. And this is a male patient. So from that perspective here, I would even consider a fibrate if the client's willing to go synthetic. A fibrate doesn't cause side effects. It's going to improve this. But at the end, if you take that total 6.1, and that's what you're targeting, 1/3 of this is contributing towards that. So now just imagine, if we're aiming for 1, that means there's 4.6 excess here. 1/3 of 4.6 is 1.5. Take away 1.5 from the 6.1 and you got to 4.5, even though the HDL is low. So here, yes, the cholesterol balance is working, but that is very difficult to bring down. And so from that perspective, we're still sitting in trouble with the ratio. And so here, unfortunately, because of the non-compliant lifestyle, we're at a loss here. Maybe consider adding a fibrate, and then we need to start improving the activity. So thank you for this case. And then, of course, one other thing can do this, diabetes. So there's very few causes of a high triglyceride. It's underactive thyroid, pregnancy, HIV treatment, especially the old-fashioned one, high use of cortisone, and then poor diet, either from a diabetic perspective or just carbs in general. So I hope that helps. Then another case from Dr. Wyatt, 56-year-old female taking cholesterol balance. So LDL, again, 4.3, not very good. And it's come down nicely to 2.1. Here, the HDL dropped a bit. And the diet actually improved, because normally when the diet improves, the HDL goes up. But here, we didn't have that. Nonetheless, the ratios are good. So again, LDL coming down by a whopping from 4.3 down to 2.1 by about 50%. And remember, the statins are known to drop cholesterol by about 30 to 35%. Most of the studies show 33%. And that's your third generation statins. So here, because of the high dose of the radicalized and the polycisinol, most times we get at least 30%. Here, we got lucky and 50%. So each patient will vary in terms of the improvement. This is a 42-year-old. He's one of our patients on one cholesterol balance. So 2024, LDL 4.4, 2020. So they were being treated by another doctor then, came to us, 4.6. Triglycerides still an issue. Good HDL, not bad, but the ratios were still off. And then the LDL come down to 3.4. So now if you do the maths from the time we had seen the client, and again, you guys are here in the way. I'm going to see if I can push this guy up without cutting you guys out. There we go. And so here, if you do the maths from 4.6 to 3.4, here we got about a 25% reduction. You see, we didn't get the 33. Like I said, it varies from client to client. But there's see what happened. And we see this every now and then. When a client gets put on a statin or a non-statin based therapy or a natural product to bring down the cholesterol, they almost seem to take their foot off the accelerator because they see the cholesterol improving, and then they're going to start eating shit again. And so look at that. Look at the triglycerides, and look at this triglycerides. So despite eating badly, that's come down. Now imagine if they eat a bit better, that LDL is going to come down and that total is going to come down. Anyway, so this person also needed some vitamin D, and we're going to go through vitamin D. Vitamin D is important because it's vitamin D and cholesterol that makes the building blocks for all the hormones in the body, right? And I'm going to go through the importance of vitamin D, but here the client was given 3,000 units of vitamin D3, and over like a 3-month period, yeah, exactly 3-month period, it went to 45. So generally, it will go up by about 8 to 10 points a month, and so you can calculate how long it's going to take to get to around 50 to 60, and then you can go on to a maintenance dose to maintain it. And we'll certainly talk about what happened. Okay, good. Okay, I think you guys get the point. I'm not going to go through every case, but look, 3.8, 2.8, the totals come down nicely, ratios improve, and here the HDL actually went up. And so, like I said, you get a varied response from client to client. So let's touch on thyroid. So thyroid disease, we're going to cover the autoimmune aspect of thyroid disease. Classically, you get Hashimoto's and Graves, and the three commonest causes, there's quite a few, but the three commonest causes that account for 99.9% of the cases of people with an underactive thyroid, by and large, majority of them are autoimmune, Hashimoto's, Then you got a small percentage of people that have had thyroid surgery, where you had a portion or all or subtotal thyroidectomy for whatever reason, cancers, nodules, and then not common in South Africa, but radiation exposure like Hiroshima, Fukushima, Chernobyl. So Hashimoto's is when the patient produces antibodies. So why do they produce antibodies? So let's go through autoimmune disease. You have a genetic predisposition in the family. Then you have a second hit, which is dysbiosis with a leaky gut. The client's going to be producing antibodies. And then if those antibodies are directed to the joint, rheumatoid arthritis, to the skin, eczema, psoriasis, vitiligo, if it's attacking the liver, autoimmune hepatitis, and if it attacks the thyroid and starts destroying it, it's Hashimoto's. If the antibody stimulates the TSH receptor, then it's Graves. So Hashimoto's, what's the goal? The goal is to get the TSH, number one, within the range. What's the range? 0.3 to 4.9. But majority of the people in the study where that TSH reference range came about were within the 2.5 level. And perfect levels, the median is 1.4, 1.6. And majority of my patients, I aim for a level of 1 to 2. Above 2 is sluggish, above 4.9 is very underactive. So this is once you diagnose an underactive thyroid, these are our goals, that's our targets, right? And then it's important to look at the T4, but you also want to look at the T4 to T3 conversion, because that's important. So anywhere between 13 and 26% of the population studied in various studies have shown to have poor T4 to T3 conversion. And then I look at the antibodies initially as well. The higher the antibodies, the worse the attack. And that tells us how bad the autoimmune condition is. What's the treatment? If we opt in for synthetic drugs, you got altroxin and euthyrox. In that sense, we're lucky in South Africa that there's no generics. So altroxin comes from the Glaxo Wellcome Smith stable. They used to have their offices in Midrand. I remember my wife got a job there when she qualified. She won the prize. And we went there, and so it was a beautiful campus. Of course, later it was sold to Aspen, and so now Aspen has the rights for the world for altroxin, but it's still an originator. Euthyrox, one of the first synthetic thyroid drugs to come out in the 1930s by Merck. Merck's background is 400-year-old company that was involved in homeopathy, and then in the early 1930s, they started doing synthetic stuff and then expanded. Those days, there were no patent laws required, so it's an exact copy of the gland, of the T4, and then you got tertroxin, which is pure T3, and then what did we do before the 1930s? All doctors were using an animal's thyroid gland. These are called glandular extracts. So it's an animal. When they die, they take the thyroid gland, they dry it, they desiccate it. So it's a powder, they weigh it, and traditionally it was called 1 grain or half a grain or a quarter grain, and that allowed you to adjust the doses. Depending on the brand, the T4, T3 combination is a bit different. So the ideal is a 44 to 6. Some of them are 40-10, and some of them are 38-12, where the T3 component's too much. So you would say, well, it comes from an animal. How can it be so different? If your glandular extract source is from America, then that animal could be a pig, could be bovine, could be cattle, and could be sheep. Whereas if it comes from New Zealand, then it's only cow or only sheep. And so that's why there'll be a bit of a variation. And then the importance of selenium and Google lipids. So selenium has been shown in a Western study in Europe, 5,000 people with Hashimoto's given 200 micrograms of selenium, and in about 70% of them, the antibodies started improving. What else can you be doing? I'm going to touch on the diet in a little bit. What about Graves, an overactive thyroid? Difficult condition to bring under control. But here the goal is for the TSH to be between 1 and 2 again. A suppressed TSH from a Graves can cause arrhythmias, can cause osteoporosis, and so and cardiac failure. So that's the worry. Antibodies, important to check, and this would be the TSH receptor antibodies. And then in patients with Graves' disease, you got to independently manage eye disease as well. So what's the Western form of treating it? It's neomercazole in South Africa. The dose can be anything from 5 milligrams to 60 milligrams, and that slows down the production of T4. Beta blockers are to calm the overactive sympathetic drive, right? So these clients have palpitation, anxieties, tremors, excessive sweating, they're shaking. And so if you give them a beta blocker, the thing comes down until you get the thyroid sorted. And then what's the role of an autoimmune diet? So if you can afford to go gluten-free, wheat-free, dairy-free, and you're good at it, it will dampen those antibodies. The important thing is that it has to be sustained. And again, in anywhere between 70 to 80% of people, you will see a reduction in antibodies, as you would see with selenium and Google lipids as well, which is what I'm going to show you. So that's the overall picture with Hashis. So 54-year-old female with sorry, I thought one of you guys are WhatsApping me. So here you can see the client had an underactive thyroid, was already treated. These are all results from their previous doctor. TSH of 4.8, T4 of 9.8, within the range, good conversion to T3, and the antibodies were whatever they were. And so, okay, so not badly controlled, but not perfectly controlled. And then you've got the client who goes off the treatment and TSH is sitting at 42. So anything above 4.94 means the patient's not taking enough thyroid hormone. And you can see 9.8, 7.9, it's gone down. And a flare in the antibodies as well. Then you start treatment, and here the T3 levels were too much. So this client was given too much T3. And what's going to happen with too much T3? It's going to start suppressing the TSH. And so you want the TSH not to be fully suppressed. And you can see better balance. But the important thing here is to see what happened to the antibodies on thyroid balance. This person was not following an autoimmune diet. So this was purely the 200 micrograms of selenium, the Google lipids, and a low dose of vitamin D. And people say, oh, but that's such a low dose of vitamin D. Listen, the study was done on 400. For many other conditions in the body, you need at least 3,000 units. So here, it wasn't meant to be a supplement for vitamin D. And so here, clear reduction in antibody count. There's another 39-year-old female patient on thyroid balance. And look, the anti-TPO activity drastically came down. In fact, normalizes. By then, the thyroid's obviously destroyed. Then you have to treat. But here, the client was not on treatment. Here, the client did not want treatment. So TSH of 7.2, T4 levels are still good. We said, okay, we'll try and work on the antibodies. The TSH receptor antibody was negative because it's expected to be only positive in an overactive thyroid. And then over a period of time, on the thyroid balance, it's normalized. You're not going to always see this kind of a result. I'm just showing you the potential, right? We see this in children. So we treat an adult like we'll treat this person. I'm making this story up now. This is a real patient, but we'd see a client like this, 39, and we'll say, oh, there's an autoimmune condition. And did your mother have it? Did your aunt have it? 40 to 60% of the females in your family will get this stuff. Unless a dad has it, then pretty much everybody's going to get it. And they'll say, oh, so-and-so had it. And then invariably they'll ask, oh, what about my daughter? And so then I tell them, Don't bring them here. Just get the antibodies checked. And if it's positive, put them on it so that you can delay or prevent the condition. What about liver? So we're going to talk about raised liver enzymes. So there are many things that can affect the liver, but we're going to mainly concentrate on the metabolic liver diseases. So liver disease that's driven by insulin resistance, by obesity, right? By type 2 diabetes. Liver disease, dysbiosis, leaky gut, affects the liver. There's drugs, so you must exclude the common things. Methotrexate, Roaccutane, chemotherapeutic drugs, high doses of statins. Those will be some of the, it's not an exhaustive list, there's much more, but those will be the common things people take. Autoimmune hepatitis, and we're not going to touch on it, but infiltrative causes. Infiltrative causes are a cancer, or a cyst, or a nodule, or bilharzia, or obstructive liver disease. So we're going to concentrate on these because that's the one you can influence. That you're not going to be able to influence as anything natural or synthetic. You need to find the cause and work on the cause. So here's a 39-year-old male with liver dysfunction. Clearly, you can see the gamma GT is raised, and over a period of time, you can see an improvement. In terms of the other liver enzymes, there's an improvement as well. Now, generally, liver disease from metabolic conditions, very difficult to reverse, right? And in fact, for a long time, the textbooks used to say, once it starts, it's not reversible. So from that perspective, to get a client to have an improvement is quite significant. And so what is it that's in liver balance that improves people's liver function? It's like a liver detox in a tablet. So in a capsule. So liver balance has NAC, N-acetylcysteine. And yes, it does smell. In nature, anything that has sulfur or cysteine will smell. I just went to New Zealand and we went to go and see the volcanic stuff, and the whole town smells. Rotorua, one of my best towns, but it smells. But you get used to the smell after the third or fourth day because it smells all the time, the sulfur, right? And so from that perspective, NAC helps the liver. Why? Because it's a precursor to glutathione, which is an antioxidant. And that gets rid of free radicals, which helps the liver. So that's the pathway we know. For those of you who are doctors, you remember when you were an intern, somebody came in with a banana overdose, you worked out the dose, and you say, shit, this person's going to die of liver failure. What did you do? You took 7.5 grams of Parvalex, infused it straight away. Then you took a lot more Parvalex, but then you infused it over 4 hours. And then the last one was 16 hours. So from that perspective, Parvalex is NAC, but in a capsule. So the highest dose you can get is 750, which this one's got. The next highest is as a brand with 600. Then I think Sorga with 500. And then there's the ACC 200. And they say on the adverts, if it's not ACC, it's not ACC. You're right, because N-acetylcysteine is stronger than ACC. So ACC will be more for nasal, and they've come up with an effervescent that is 600 as well, but the highest is 750. But in 2 capsules, you get the 750 plus Kudzo, dandelion extract, green tea extract, vitamin E, the permissible dose that's allowed in South Africa, alpha lipoic acid, and so it's got all the, and milk thistle, it's got all the right things to help the liver all in one. That's why we've seen this kind of an improvement, right? And so here's another client, 66-year-old, gamma GT raised, and you can see over a period of time a complete improvement in 6 months. ALT went down, AST went down. So this client was lucky and we got full recovery, and you can see that there was no infiltrative cause. So when you have an infiltrative cause, both the gamma GT and the alk phos go up equally. In other words, if you look at the upper limit here, and if it goes to 280, that means it's double, then that one will also be double around the 88, 90 mark, right? That's when you know it's an infiltrative problem, like cancer or pancreatitis or gallbladder disease or bilharzia. That you're not going to fix up with this. Nothing can fix that. You've got to get rid of the cause, open up the ducts, right? So if it's raining and downstream, you don't open up the dam walls, you can do whatever you want to upstream, ain't nothing going to happen. You've got to open up the dam walls. And so to let the water run through. And so it's the same thing here. Whereas intrinsic liver disease is measured by ALT and AST going up, these two. Okay. Another 60-year-old or 62-year-old. I'm not going to label on it, but look, gamma GT comes down, liver enzymes 123, almost 1/3, 57, 28, all good. Again, no infiltrative. It was mainly intrinsic liver disease. Again, I'm not going to label on it. There's the improvement, and it wasn't infiltrative. So what about just NAC? So when liver balance is not enough, I add NAC. Or in some clients, you just use NAC on your own based on what your needs are in terms of what you're trying to repair. So there we go, 750 milligrams N-acetylcysteine, and yes, it's going to smell. And in this client, why was NAC chosen on its own? Not only for liver disease, but look, this is a diabetic patient who had proteinuria. Now, proteinuria is not known to reverse. It only gets worse. And that's why one of the highest cardiovascular risk factors is the presence of proteinuria. It beats smoking, it beats diabetes, it beats blood pressure, it beats cholesterol. That's been studied. So it is one of the most potent cardiovascular markers. So, of course, the textbook says it's not reversible, but this was just to show you on 750, look what happened. What happened to the creatine? And this wasn't a filtration problem. Can you see the client always had a good GFR? So that's why I just chose NAC on its own. And yes, you can go up to 3 grams with complete safety. So you can use up to 4 NACs. So sometimes I will use 2 liver balance, and if I need more, I just add 3 more NACs, one at a time, by looking at what the results are getting. And here in this client, we did go up. So this was up to this point 1, but then we went up because here we still need more improvement, right? And so if 1 did it, high dose ought to get better results next time. And so we'll wait and see what happens. Again, this client didn't have too much of an issue, so NAC, and there's been an improvement. Now, one of the things about NAC is that it doesn't cause reflux disease, but if you've got reflux, it's going to make it worse. So then I tell my client to take liver balance and NAC just after breakfast, not late at night, because you're going to lie down anyway, and then you're going to make the reflux worse. So if the client's got reflux, it may make it worse. It doesn't always, but may make it worse, but it's not the cause of it. Here's a client with both 2 liver balance and 1 NAC. So it means 715 there, 715 there, 1.5 grams with 6 of the other guys, and there we go. Full improvement. What about vitamin D? So in South Africa, vitamin D is not allowed to be sold off the shelf without a medical script. It's a law. So that's why people keep theirs 1,000 or lower. So that's an easily available product that can be used. It's mixed in MCT oil, which is the healthy oil. Up to now, a lot of the products that came in drops were using Ceph oil, which is inflammatory, right? That's the wrong omega. And this one has got a lemony flavor, an orange flavor. Kids don't like the mint, so that's why we went for that. So 1 drop gives you 1,000, and the bottle lasts forever in 3 days. Now, 3,000 units. You need a script for this one. Why was 3,000 chosen? Most people with metabolic conditions, most people in South Africa, they don't have any sun exposure, will need at least 3,000. In pregnancy, you may need more, and in conditions like thyroid, insulin resistance, estrogen dominance, adrenal issues, they tend to need more. So you can take 2 or whatever and see where it goes. The 10,000s are compounded. That's why we had to take it off. We hit the 10,000s and it becomes a nightmare with Saptra to get something like that. So what's the role of vitamin D? Let's first talk about the source. The source of vitamin D is sun. That's it. All your foods have vitamin D2, which means you need to be sitting in the sun, exposing 40% of your body for at least 40 minutes if you're light-skinned. As your shade increases, so like if you're like me, you're going to need at least 60 minutes to 80 minutes. Now, let's just work out what 40% is. You know, at medical school, they teach you the rules of 9 to work out when you're at a scene where the house burned down and you get there and there's people on the floor. You need to quickly eye the situation and go and see who you're going to try and save. Because over a certain percentage, the client is unlikely to make it. So you've got to rather direct your help to somebody that you're likely to make it. Right. So that is 9%. That is 9%. Your legs are 18%. 18%. 1%. So if I'm lying on my back to the sun, the best I can do is 50%. If I cover this part with a body bikini or a vest, then I take away 9% because it's 18%. That means you're left with 41. So unless your client is in a body bikini for 40 minutes before 11 o'clock because we've got the ozone every day, you're in shit. If you put sunblock, nothing is coming through. So when the patient say, oh no, I walk every day in the sun, yeah, this hand is less than 1% and there's 1% and only the top, because you can't have both sides exposed at any one time, right? So I'm laboring this point because, guys, it ain't going to happen. And there's no point in just telling them to go and sit in the sun. They're not. So the only other source is supplement, because the supplement with D3 doesn't need the sun for conversion. It's converted already. What's the role of vitamin D? For over 100 years, we had a very bone-centric view to vitamin D. We thought vitamin D was only important for bone. Hence, the reference range that you see with Lancet and Empath. It's written there. Recommendations by the Osteoporosis Foundation. It's a bone-centric reference range. They tell you something like insufficient or sufficient. Sufficient for bone. But if you take out your medical textbook and you look at the reference of vitamin D, normals 30 to 100. How can 20 be the right number? Think about it. Why would you say the reference is 30 to 100? So for bone, you can aim for levels of around 30. For metabolic conditions, around 50 to 60. Insulin resistance, diabetes, cholesterol, blood pressure, obesity. For immunomodulatory properties, autoimmune conditions, cancers, whatever, you want higher levels, 60 to 70. If you're looking to prevent cancer or you're in cancer treatment, 70 to 80. It's toxic above 100. What's the toxicity? Hypercalcemia, not death. Once you bring it down, the calcium level comes down. So just know what you're trying to aim for. So here's a patient with combination treatment, 35-year-old client with an underactive thyroid, and you can see over a period of time the TSH improves and the antibodies on thyroid balance, Google lipids and selenium, a huge improvement. In terms of homocysteine, client had a homocysteine of 19. Anything above 6 means there's poor methylation. And you can see over a period of time it's come down, inflammation's down, and then vitamin D from 19 to 71. Why 71? Immunomodulatory properties with the selenium. estrogen dominance. So one needs to understand the estrogen pathways to understand this condition well. And if you take pregnenolone and you give it to a client and you test the urine 24 hours later, you'll see 24 estrogen metabolites. There's three main groups. You've got estradiol, you've got estriol, and you've got estrone. Estradiol is the most ubiquitous female hormone in reproductive life. In pregnancy, estriol is the more dominant estrogen. And as you get older, estrone becomes the more dominant one. By the way, the original HRTs had estrone. Now, those are the three big categories, right? Estrone is the one you don't want. If you go further into it, and I've done a talk on this, you get 2-hydroxy, 4-hydroxy, and 16-hydroxy. One is okay, one is neutral, and one actually promotes cancer. So one needs to understand these pathways if you're going to get into the game of managing these patients. The important thing is that throughout the cycle, it doesn't matter where you're in a cycle, your maker in biology made sure that estrogen needs to be balanced by progesterone. And that's how the entire hormonal system works. T4 and T3, TSH. PTH, calcium, vitamin D, magnesium. DHEA, cortisol. Estrogen, progesterone. Insulin, glucagon. Can you see? It's about balance, right? And so when you have too much estrogen and the body can't make enough progesterone, you have a state of estrogen dominance. Where would you see that naturally? Naturally, before all those extra estrogens were brought into the environment, you saw it in the perimenopausal state. Late in the perimenopausal state, just before menopause, progesterone is the first one to drop, and estrogen is still shaking very high. And that's when the symptoms are most enhanced. What are the symptoms? We've done this before. Breast tenderness, water retention, mood swings before the cycle. Don't normalize it. It's an abnormal symptom. Most people suffer it because we're estrogen dominant now. Zits before the cycle in the T-zone. In the 40s, pigmentation. Adenomas in the breast, fibroadenomatous breast disease. Higher risk of fibroids, endometriosis, cysts, first trimester miscarriage, and the middle spread from a weight perspective. So that's why you want that imbalance. Progestin is not the same as progesterone. When you infuse progesterone during cardiac intervention, you see vasodilatation. You inject progestin, vasoconstriction. Complete different physiology. That's the one that's going to increase your risk of clotting and cardiovascular disease. So why do we have the state of estrogen dominance? Well, as humans, we put in out 2,000 new chemicals in the environment every year for the last 25 years. Some of them are called forever chemicals. In other words, you can't get rid of them. And some of them are called endocrine disruptors. They go and they stimulate the receptor. And they may either upregulate it, downregulate it, or block it. That's how come they're disrupting the system. You get xenoestrogens. So insecticides, pesticides, herbicides, they are molecules that can mimic the effect of estrogen at the receptor. Estrone. So many people are on contraceptives. They pee. It gets into the groundwater. No filtration system in the world can take it out. So it accumulates and then we drink it. Men become estrogenized and our fertility is halved in the last generation, and females get extra estrogen, and then they've got higher risk of breast cancer, fibroids, endometriosis, miscarriage, and infertility. That's how come that's been changing at such a fast rate. Now, had we put progesterone in the environment, we would have probably had less estrogen dominance because we would have had an excess of both. Heavy metals can disrupt the endocrine system as well. Some of them can mimic estrogen. And so in this range, there's heavy metal neutralizer that has NAC, again, 600 milligrams. There's a detoxing agent. It's got EDTA that removes heavy metals. It's got chlorella and spirulina. That's why it smells so badly, because that comes from the ocean. And it removes environmental toxins. Spirulina and chlorella also helps the pH of the body, and it's a very good source of multiminerals anyway. So that's the role of heavy metal neutralizer. And for those of you who have complained to Leonie about the smell, it's not gone off. I take this shit every day. That's how it smells, because it's got chlorella and spirulina and NAC. So EDTA smells, NAC smells, chlorella smells, spirulina smells. You can't, and it's double coated. So imagine if it wasn't, how much more it would smell. But you don't smell. It's just the product smells and it detoxifies. And then animal sources of estrogen. So when an animal needs, okay, when an animal is farmed, it sounds very bad. I'm a vegetarian, so know where this is coming from. That animal is looked at commercially and said, how do I get it to 100 kilograms as soon as possible so I can take it to the market? And so it gets pumped with antibiotics and hormones. It's not normal for a cow to give you milk every day when she's not pregnant. It's because there's estrogen there. That means the estrogen sitting in the meat and all its byproducts, milk, yogurt, cheese, butter, sour milk, sour cream, all of that. The hen, it's not normal for a hen to lay an egg every 26 hours. She's been pumped with hormones. And so it gets into the egg and her meat. And so you look at water source, animal source, too much soya, heavy metal neutralizer, estrone, xenoestrogen, and we in shit. And so from that perspective, there's a 53-year-old female, classic perimenopausal time in their lives, and look at those swings. So people say, okay, no, but when did you do the bloods? Does it matter? Whether it was done in the second half of the cycle, then the progesterone is meant to be 116. If it was done in the first half of the cycle, half of 116 would be 58. Does it look like it's between 58 and 116? No. Does this look like it's between 9 and 19? Yeah, not too bad. Can you see that? So can you see within one client, a month apart, look at the fluctuation. Look at the fluctuation. And so here, they're more or less in the same part of the cycle. And yet, look at the vast changes, right? And so from that perspective, estrogen balance normalizes the estrogen. If the progesterone is not enough, then you need to add progesterone. Vitamin D, the client went from a low level here, sorry, it's cut out to 44 to 50 to 58. Liver was an issue. Bone balance is important. So I never touch on that. But anybody above the age of 45 or 50, remember estrogen is anabolic to the bone. So basically it's helping prevent bone loss. So when a female goes into menopause, then the risk of osteoporosis is very high. And so if humans live long enough, all of us will have osteoporosis. Men have a lag period of around 15 years because we still have testosterone a bit longer, and testosterone is a building block for estrogen. And so that's how our bones are protected for about 15 years longer than a female counterpart. So I give all my clients about 45 to 50 bone balance, and it's a clever product because in one big product, you have calcium in the glycinate form, magnesium in the glycinate form. How much calcium do you need? 1,000. What's the worst calcium diet delivering? 550. How much do you need? Only another 500. That's why it's got 500. If this guy had 1,000, now you're getting 1,500. That's on your worst calcium diet. If you've got a good calcium diet, you're getting way too much calcium, and then it's a problem. And then it's got K2 to prevent the calcium from going to the arteries, so vitamin K2 and calcium from a complex, and then it goes straight to the bone. And he's got vitamin D. People say, oh, but so little, 1,000. Yeah, go and check what Menacal's got. Go and check what Calmeg's got. Go and check what BCalDM's got. Only 200 to 400. This one's got 1,000. That's all that's allowed. And it's got boron. And so very clever, inexpensive product to get 5 things in one. And that's what this client was on, and liver balance and homocysteine. I don't see the homocysteine here, but client was given homocysteine. What about magnesium? So the magnesium boost is slow release. There's only 2 slow release products on the market. This one and Slowmag. Slowmag, it's only the small tablet that is slow release. Capsules are not, and the effervescent is actually quick acting. So the tablet is 43 milligrams. This one is glycinate. That one is not glycinate. And you've got 1,000 milligrams in a colorant free. So it does not have red 40 and red 3 or ferric oxide as a colorant. Some of you that have been using this product for a long time, you'll notice that it's gone from a light pink red, almost like this laser color, to white. And people say, why? Because the homeopaths were asking us to say, why is this thing red? It's got a colorant. And we said, yes, it's got a natural food colorant. But after 400 million questions, it was easier to just get them to take the color out. And when it did have the color, it was the only one that had a natural color. But just to get away from the question, they've taken it out. But all the others still have, unfortunately, the wrong stimulant, and that has been linked. I'll allow you guys to go and check on Google and ChatGPT what those colorants do. What kind of magnesiums you get in the market? Magnesium oxide, the worst form. It's hardly absorbed. So why is it on the market? Because it became popular for people who are constipated. It makes them go. So if you're taking it for bone or for any one of its other 400 functions, it ain't going to do it. Calcium carbonate. So carbonate by nature, its pH is more alkaline. And so that's why it's very poorly absorbed. This is in its natural state in bone and lime deposits, because that's where you get the magnesiums, right? And so very poorly absorbed. In terms of citrate, because these 3 are chelated, that means they bound to an amino acid, and because the body is always looking for protein, when it sees an amino acid, it picks it up, and that's how your magnesium gets absorbed. So citrate is better absorbed than carbonate, threonate even better, and glycinate the most easily absorbed. Again, the highest is 1,000, and this is the only slow release, and it's a glycinate form. What's the function? 400 different pathways. It acts as cofactors. It works on many hormonal pathways, many enzymatic pathways, neurotransmitters, acts as a nerve stabilizer. For clients with mitral valve prolapse, magnesium decreases arrhythmias and palpitations and chest pain. And then its most important function is acts as a second messenger in many of the chemical pathways in the cell. But we can't go through all 400, right? And so you want to aim for levels of at least 2.2 midway through, especially if it's so important. Red blood cell magnesium is your best way to measure magnesium because it's intracellular, which is different to the serum. So when you're measuring serum magnesium, you want to be aiming for at least 0.9 or more. The reference range is 0.6 to 1. So here you want better levels. This client was also on homocysteine. You can see the homocysteine levels were not good here. 16, very poor methylator, and that improves. Vitamin D was very low, 18, slowly going up to 34, and that was in a 3-month period. So you just carry on, and I must have doubled it to go up faster. Once I get to around 50 to 60, I will slow it down to a maintenance dose, either offer them drops once a week or maintenance dose of 3,000. And then here, why is this here? NAC to help renal function. So you can see an improvement in GFR, huge improvement, right? And don't worry about the cystatin C. That's a more accurate way of finding it. But here you're comparing apples with apples. About a 20% improvement. And we know it's very difficult to get improvement without the SGLT2s and without managing the diabetes and blood pressure well. This patient had none of those. But anyway, I still needed to improve. And the NAC did it. What about homocysteine? You can see the heart here, and everybody thinks it's only for cardiovascular risk, and it is. It's very important, but it does many other things as well. So let's go back to the pathway called methylation, and it's got a lot of vogue now on YouTube. And so it's good the patients at least get to go and learn a bit about methylation. And so if you go back and you look at the Framingham study, this is a town in the USA that a university sponsors, and they've been following this whole town, every individual that has come there or was born there for 4 generations now. And the entire town signs a document to say they will allow themselves to be guinea pigs and everything will be for free. So that means the university does a CT scan, an MRI, full bloods, genetics, get fingers prodded everywhere once a year, and it's been a longitudinal 4-generation study. Now, those kind of studies are good because there's no intervention. They're just watching these people. Some exercise, some don't, some are stockbrokers, some got a relaxing job like endocrinologists, some are meat eaters, some are vegetarian, some are tall, some are short, somebody's father was having shitty genes, the other one was good. You don't interfere, and you just watch them. And the Framingham study, not Barna, the Framingham study showed that when your level is above 6, like 6.1, then you're 2 times more likely to get a stroke than the general population. If it's above 9.6, 3 times more likely. If it's above 12.4, 12.6, I forget the number, 4 times more likely. So why is the upper limit so high on our reference range? It's called acceptable risk. Some of us have to be fodder. Can't treat everybody for everything in life. The point is, that's why I aim for 6. So for those of you who do genetic studies for methylation, just please comment a bit on the side, and we'll go through it later. But if you do a genetic study and you show your client, you've got a methylation problem, it's this gene. Oh, doctor, what does that mean? This means you're not methylating well. And then you say, actually it's heterozygous. Because you can get heterozygous or homozygous, double gene or single gene. Doctor, what does it mean if I got a single gene? You're a poor methylator. What's my treatment? TMG. Oh, and what if I had homozygous? TMG. What happens if you got the other gene? If you're heterozygous? TMG. What happens if you're homozygous on the other gene? TMG. What happens if I got both genes, both homozygous? TMG. Is there a point in doing genetic studies for 6,500? No. Just do a $80 test. If the level's above 6, treat. Who the hell gives a shit which genetics is involved here? Because your end game is to get that homocysteine down as low as possible for risk. So where did this concept of methylated folate come? Because in the early days, when you had homocystinuria, the treatment was folic acid. And then, if you want females who are wanting to fall pregnant and you want to decrease the risk of neural tube defects in their children, they said if you give folate, you will improve and decrease the risk of that. So along came later methylated folate. That then got translated to everybody who's got a high homocysteine needs methylated folate. And what about the methylated B6? You think the methylated folate can jump and fix this guy? No. Can your methylated folate fix this guy's problem? No. Can methylated folate methylate all the other pathways? No. So the treatment for methylation is actually TMG, trimethylglycine. And yes, if you can methylate the folate for them, you don't have to wait for this guy to do it, but it will do it. You can methylate the folate, methylate B6, and methylate B12. That's what homocysteine balance got. It's the only product with 1,000 TMG with that, and with that. Now, if that's not enough to bring it down, then add SAMe separately. Oh, but now why didn't you guys just put SAMe there? Because SAMe can also activate serotonin. And what about the people who got normal serotonin? You're going to push up the serotonin level and then make them obsessive compulsive. So rather wait to see if this is not enough and then add 100 milligrams of SAMe. 9.7, 3 times more likely to get a stroke, and now almost 2 times likely heading towards the 1 time likely. Can you see that? This patient was on cholesterol treatment as well, so coming down nicely. Look at that LDL, finally gets to 3. Vitamin D was an issue, so 17 to 48. So some people like taking vitamin D once a week. Some people like taking it every day. I just dose titrated it and found this client. It works out to about 6,000 drops. 6,000 drops per week. Those of you who are using the 5,000, do you really think it's got 5,000? If it's sitting on the shelf, Sapra doesn't allow it, and people are getting it without a script, you go figure that one out. Case study from Dr. Vahid again. So Dr. Vahid's been very active. Good. I've been treating this patient from March. His vitamin D has been addressed. Lipogram and insulin are improving on cholesterol balance. However, HbA1c is not decreasing. Uric acid levels remain high. Can be related to insulin. He has been weaned off Puricos. Gout attacks, yet levels remain elevated. Cholesterol balance was very effective despite slow progress due to high stress. Oh, this seems like it was the same patient, right? Okay. So let's just tease this out. This patient is a totality. So there's your client, comes to you, and I can tell you without Dr. Vahid telling us the symptoms, this client wakes up tired in the morning, has energy dips between 2 and 4, has cravings after 8 at night, libido not good, ability to deal with stress not as good as before, and there's a bit of burnout, insulin resistance. Where's the fasting? Glucose. Nope. So ideally, you want to do a fasting glucose and an insulin so you can get a HOMA index. A fasting insulin on its own becomes meaningless. So don't just look at it as a number, right? HbA1c is a late sign, but patient's already pre-diabetic. So above 6.5 is diabetes, above 5.6 pre-diabetes, some say above 5.8. Either way, very insulin resistant and pre-diabetic. So the patient will have central obesity and fatty liver. Let's look at the fatty liver. There we go, confirmed. High gamma GT, not an infiltrative problem because alkaline phosphatase is 93, ALT, AST above 20. We got a fatty liver here. Iron stores are fine. You only really need 16 to 20, enough in the blood. GFR 72, not bad. Homocysteine, we need some work here. Vitamin D was very low, 17, no symptoms coming up. B12 was good, and it will be interesting to see where the homocysteine is. There we go. So although the vitamin B12 levels were fine, can you see how shitty the homocysteine is? This guy's a poor methylator. Giving them more normal B12 ain't going to do the trick. It has to be methylated. Let's go a bit further. C-reactive protein, average risk of cardiovascular disease, 1.1, not bad. Cholesterol, we went through that. It was shitty. And then uric acid, high. Creatinine, unless this patient on creatine, we need to work on this. So, number one, in case this patient's on creatine, it's not for sissies. Works very well, especially in people above the age of 45 for cognitive function, for retaining mass and keeping the protein on the body. But you need at least 2.5 to 3 liters of water a day. Otherwise, abandon ship. Don't try and take something to improve your muscle and cognitive function and mess your kidney up. What would I do here? I would definitely try and work on the diet a bit more. If I'm not winning, I'm just going to put them on a fibrate. Yes, he already put him on the cholesterol balance, so it's working. I would put this client on liver balance 2 a day after breakfast, because with that kind of a punch, probably putting pressure, probably will have reflux. I don't worsen it. And later I may add NAC because we're not winning with the creatine here as well. So if that NAC is not enough in the liver balance, then I will add that particular guy there. In terms of iron, that was fine. Homocysteine, 2 homocysteine balance, and tell his mother, father, brother, and sister to take it as well. That is going up. We can just go a bit faster. Aim for at least 50 to 60 here because of the metabolic state. DHEA, male patients, so 46, I would start at 37.5. Aim for at least 8 to 9, and then see what happens with the cortisol. In the meantime, I can't leave him being tired, so I would add burnout, 1 in the morning, hoping to get to about 250. I'll put it for 2 months, wait for the DHA to come right, and that should then take over. If it doesn't, you have 3 causes of a lowish cortisol. Cortisol, we were aiming for 250 to 350. So, low DHA is a cause. Once it's fixed and it's still bad, that means the patient's taking cortisone, which can suppress it for up to 12 weeks. If they're not on cortisone, then it's the gut microbiome. And overriding all of this is stress. In terms of this level of insulin resistance, I'll offer the patient either natural treatment or synthetic if it's there. Leonie told me she was going to put the slide. Glucose balance, I think it's coming next week. Finally, a product with 7 items in it. The Rolls-Royce is an 85% extract of 100 milligrams of the best grade berberine, with no gastric side effects there. Betamelon, which is Kerala, an Indian herb, per capsule, 266. If you use 3 of these, 1 before each meal, 3 times a day, or 1 twice a day, you can multiply that figure. Goat root extract. Remember, where did the world get metformin? It's an extract from goat root. 200 milligrams. Garcinia HCA, popularized by Dr. Phil, who was with Oprah. 200 milligrams per capsule, so a total day dose would be about 600. You've got D-chiroinositol, 100 milligrams. You've got Morris alba. It's an extract of white mulberry leaves. And look at that extract, 66 per tablet, which means you get a total of 200 per day. And then chromium picolinate, 100. So if you take 2 or 3, you can go up to 300. So currently the best combination of natural products to bring and help insulin resistance. Insulin resistance is the basis of one of the 7 causes of weight gain. It's the basis of fatty liver. It causes PCOS, polycystic ovarian syndrome, and it's the cause of diabetes. So I would then offer Dr. Vahid's client either that product with 10,000 steps a day and watching the high GI carbs. They're allowed a cheat day once a week. And if the client opted for something synthetic, I'd offer them either oral or injectables. If it's oral, off-label use of glucophage. For this, I'll go up to 2,000 and warn them that the drug can cause nausea, bloating, loose stools in 3 to 5% of patients, and then it passes in most. If it doesn't, we got to stop or lower the dose. Second option, off-label use of SGLT2, and that will make the client pee out the sugar, equivalent to 440 milligrams of sugar, but the client needs to drink 2 glasses more water a day. This client is already close to dehydration, so we need to watch that, or you can use that as a combination. Or they can go on to one of the GLP-based therapies, where you got your daily injections, and now there's a generic out. You've got your weekly injections with 3 different companies. You've got a higher dose of the GLP, and then if you want a GLP-GIP combination, then the 6 doses. Whatever it takes to bring this level to between 3 and 5. That's when we talk about reversal. Today, I had 2 clients that have reversed their type 2 diabetes. The one was just on 3 maximum oral agents, HbA1cs were high. The other client was actually on insulin and 3 oral agents, and now has an HbA1c of 5.7, a client from Bloemfontein. So here, when these products are used early and wisely, you can intervene. The patient who was on insulin had type 2 diabetes for 12 years and has been on insulin for 7, and took us 6 months, and they're now completely off all 38 units of a long-acting Rhizodec. Excellent insulin, but anyway, we managed to get him off it. Okay, I think that covers that one. Unless there's questions, and you guys will put it in the comments, and I'm going to go through it again. Remember, you can use a combination of all of what I've spoken to get faster results if the client can afford it. Good evening, Leonie. This is my case study for Thursday. Thank you. 18-year-old female referred to me for leaky gut syndrome, hair loss, extreme fatigue, emotional instability. The referring doctor did not test for thyroid antibodies. Should she start altroxin, or would like something like thyroid helpful in this case while I work on a gut issue? Right, let's look. Di is somebody from Zimbabwe. She takes care of a lot of our patients, and she's in the field of dietetics and healing through improving gut and eating. TSH, normal, 1.5. If it was above 2.5, it would be sluggish, above 4.2, underactive. So at the moment, whatever we're going to see next, the pituitary gland is happy with. So you're sitting with 10.6. That is below the range. Yet the conversion to T3 is okay. So this can happen in 2 situations. Fire the lab, because there might be a lab error, or very rarely you can see central hypopituitarism. When it's central hypopituitarism, that patient is not 3 to 4 kilograms overweight. There's a lot of weight. So this, I would say the start is to repeat the test, if possible, at another lab. So that way you've got either you've got a different machine, right? And a different pathologist. And then I want the antibodies, because this patient is from Zimbabwe, so there's no radiation fallout there. Presumably nothing on history tells us that the surgery, and then we don't have the presence of antibodies. Now, if the antibodies are there, then this guy ain't going to do the trick. There isn't enough selenium there. So you're going to need selenium and Google lipids to improve the antibodies. So here, repeat the test, preferably at another lab with thyroid antibodies. Estradiol of 50, progesterone of 1.1, so we needed 5 to 10, so a bit of estrogen dominance there. I don't know why that was done, because in menopause we use this. If it's above 26, then it's menopause. In youth, you can use it as a marker of PCOS. The ratios would be 3 to 1, but I don't find it to be too helpful. That would not affect fertility or weight issues or galactorrhea. That's normal. Androstenedione, I normally aim for levels below 2.6. So this one's just gone high, and it could account for some hair loss. So could the thyroid if the antibodies were positive. The testosterone is not a problem. So here you would want to check the other androgen DHEA, because fatigue is easy. It can either be low ferritin levels, it can either be thyroid, it can either be adrenal DHA cortisol issues, it can either be gut microbiome or mitochondria. Very easy. This is not rocket scientist stuff here. So for now, we're going to repeat thyroid, check the ferritin levels, check the DHA and cortisol, and for now, I think DHA and this guy are going to be responsible for the hair loss. The fatigue could be thyroid or adrenal to start off with, and work on the gut that can cause fatigue, and there's no reference to any gastric symptoms, but yeah, I would work on that. Emotional instability, I mean, it could just be Trump or the ratio between estrogen and progesterone. So I don't think this guy is going to be helpful. Leonie, Kim. 10 children take the new gut therapeutics allergy asthma product. Just got delivered today. Yes, it's actually designed more for them. It was designed for my child who's got allergies. And so do I to our two beautiful little cats. So there has been lots of work showing that the three bacteria, when given in abundance, can improve allergies. And then it's got three Indian herbs, Asian herbs, that also helps with upper respiratory issues. So yes, can be taken. Dear Leonie, I trust you're well. Dr. Bana may use his blood report to show a treatment plan for this type of a patient. My question to him is why Hashimoto thyroiditis is so prevalent nowadays, even in young girls. Is it a post-COVID thing or something else? How to prevent progression in hypothyroidism aside from thyroid balance? I've also attached an 8-year-old's blood result as a screenshot. Okay, so before we go to these cases, let's discuss this. This is very important. So the NHANES study, all capital letters, is a huge study conducted by the NHI in America, NHI in America, where they survey general population to look at trends and causes and prevalence for cholesterol, for blood pressure, for diabetes. So they worked out the prevalence of hypothyroidism about 15 to 20 years ago. I've got the exact date in my master's, my PhD, which I haven't published till and everything is done. I'm self-sabotaging on that one, was 4.6%. So if you take Americans, 4.6% of them have an underactive thyroid. Fast forward to 3 years ago, that same study showed that the prevalence has gone up to 9.6%. If you look at the 8-city study in India, 8-city means they took the 8 biggest cities, screened 5,000 people, and upwards of 13% of females in India have an underactive thyroid. In South Africa, if you look at my PhD data, so if you white, the risk can be up to 15%. If you Indian, around 12 to 13%. If you have mixed origin, around 9. And if you indigenous to this beautiful soil, it's 2%. So autoimmune conditions, many factors. As you move away from the equator, the risk increases. As you move from rural to urban, it increases because we're getting closer to sterility. As we become more westernized, autoimmune conditions are going up. There's a race difference, which I've just highlighted as well. So why is it so prevalent now? Is it because we're screening for it more? No, that NHANES data does show that it's increasing. And that's because look at all the shit we've done to ourselves. For thousands of years, milk was not pasteurized. Then come Louis Pasteur and messes everything up from a milk perspective. I mean, look, wonderful work. Make no mistake. All his findings was important. But that's where the concept of pasteurized milk comes, right? And so now, where's our source of good bacteria? For thousands of years, you look at all old societies, they always had something fermented to be eaten every day. Call it kefir, kombucha, raita, tzatziki, fermented fish, inkombuti. Whether you look at South America, China, Tempo, Japanese, Koreans, they all had some kind of fermented food that they ate every day. Now we sterilize. In the 70s, what's going to happen? At the same time, we start taking too much antibiotics. The animals get pumped with antibiotics so they get fatter. That antibiotic comes into the food, into the byproducts. We start putting preservatives in food. We change the entire gut microbiome. That's why the prevalence of allergies have gone up. That's why asthma is on the increase. That's why thyroid is on the increase. That's why all autoimmune conditions are on the increase, because we've changed our gut microbiome. I mean, I think I told you guys on one of the talks when I did the GIT talk that I'm still looking for the gynae or that gynae's offspring who told my mother when I was born to not give me breast milk and give me cow's milk. That's why I'm allergic to my bloody cat. So I still want to wring that guy's neck, but that's the kind of advice our mothers were given. I was born in 67, so that's the kind of advice they were giving the mums there. Can you see how the pendulum swung? Where we said, no, breast milk wasn't good. Now breast milk is good. So these things keep changing, right? So that's why there is higher prevalence. Has COVID got something to do with Hashimoto's? COVID has been shown to have long COVID. It affects the adrenal gland. It affects clotting. It causes spike protein. It causes pericardial effusion. It increases heart failure, causes lung disease, and causes many things. What I forgot to tell you in this new range is Vescu Clear. Vescu Clear, there's a publication in the World Journal of Cardiology, 26th of February 2025, published work showing that nattokinase, curcumin, anyway, this product is coming out. You will see bromelain, curcumin combination with nattokinase getting rid of the spike protein. I think that comes in the next 2 weeks as well. I've been on it already. One of my patients' lawyers have been on it whose fibrinogen levels were high, D-dimers were high. The day they dropped the sample off, there were 2 bottles sitting there. I was going to take it home to start. There's Natalie in front of me. I see all of this. I said, yeah, you're a lawyer. I shouldn't give it to you because you can sue me. It's not coated. Take the shit. And yeah, it's to help that kind of stuff. So does COVID directly cause autoimmune? We don't know. That hasn't been studied still, but we are seeing more than we used to see before. How to prevent progression of hypothyroidism? So once it started, the only thing you can do is work on the antibodies. How? Autoimmune diet with thyroid balance or thyroid balance on its own. Use it for at least 6 months and then repeat the antibodies. And if you've seen a reduction, carry on. If you're not, you may need to abandon ship. Here's the good news, guys. Around 8 weeks ago, the guys who won the Nobel Prize in medicine uncovered the pathway to autoimmune conditions. Do you know what that means? 10 years from now, there's a cure. Because once you know how to go to Japan, you can map a pathway, either by plane or boat or train or whatever, once you know what's in between you and Japan. So we never knew what was the cause, what's the process of autoimmune, the full pathway. They've uncovered it. That means because of the numbers I mentioned in India, take 13% of 1.3 billion people, take 9.6% of 360 well-to-do Americans. There's a big market there. That means the guys are going for a cure, which will come in 8 to 13 years. That's how long it takes to develop a product. So I think the cure is coming. Let's wait and see. Now let's look at this 8-year-old's result. So the antibodies are positive. So no doubt this 8-year-old's mother or father has got autoimmune conditions. If a mother's got Hashimoto's, then 40 to 60% of her offspring, all her females, her granny, her aunt, her mother, her nieces, her daughters, 60% of them will develop an underactive thyroid. And so here there must be risk. And at the moment, the T4 levels are perfect. TSH, I wanted 1 to 2. So we watch this, work on this child's antibody, work on, now, here I would say throw the diet away. I mean, how do you get an 8-year-old not to have gluten, be gluten-free, wheat-free, dairy-free? And can they do it consistently till they're 93? Unlikely. So it's worth a try, but you've got to understand that 8-year-olds need to be 8-year-olds. You can't have another kid having something and then you deny your kid. There's going to be a cured thyroid, but with lots of anxiety and self-harm issues later. So here, thyroid balance, get the gut microbiome sorted by either sending the stool off for analysis or do a live blood analysis with Kim. I had put her data down earlier last year, or contact Leonie for her details, and then work on the gut. Work on the gut. Okay, this comes from that same request, that 63-year-old female. There's another patient. So here, TSH of 9.2. Clearly underactive, antibody positive. This can only progress. So you start treatment. Offer the client all the options, either synthetic T4 or glandular extract. Get the TSH to 1 to 2. Then look at the T4 to T3 conversion. If the conversion is not good, then consider adding T3. Antibodies, I've spoken it ad nauseum. Autoimmune diet if you can. If not, thyroid balance. If you can do both, go for it. Work on the gut microbiome. Get that vitamin D to around 70. This client is insulin resistant. Again, always pair it with the fasting glucose. Look at the HOMA index and the quickie index. That way you can speak to either insulin resistance or insulin sensitivity or both. Glucose balance with 10,000 steps a day. Watch the high GI carbs, or add glucophage, or an SGLT2, or a GLP. As long as 3 months later you check it, you're aiming for 3 to 5. If you're not there, carry on, increase the dose. If you're getting good results, 12.8 to let's say 6 or 7 in the first 3 months, carry on. If you're still stuck at 11, increase the dose. Adrenal. DHEA plays an immunomodulatory role. It improves the Th1, Th2 balance. Another way to look at it is CD4, CD8 balance. So by getting this up, this is female, yeah, female, I would aim for 3.5 to 4.5. That will also help the cortisol, because the high cortisol feeds into that. And here we're waiting for a cortisol of 250 to 350. So I would use 63, 12.5 milligrams of DHEA. Check it 3 months later, and probably add stress damage control, which is ashwagandha, rhodiola, and mushroom extract, 1 twice a day, and we'll see what happens. I hope that works for you. So very exciting, will be available next week. So the allergy one is going to be available next week. The prostate one should be end of next week. The lean, which has got over 500 billion bacteria, of which 30 billion are Akkermansia. All the other 6 also improves weight, with each one having a supportive published study, and very well priced. But more importantly, all of those are going to get delivered into the intestines, whereas every other probiotic currently on the market, except for Probitech, all of them die to some extent. Probitech, very good technology, but what's the point of having 10 billion or 20 billion? You already had that. What's 10% of 450 billion, 90 billion? What's the point of putting 10 billion then? You're still lower than what was on the market. It's not going to help us cure our patients that have stubborn. Oh, here's it. Oh, right, there we go. Akkermansia. 15 billion per capsule. The product you need 30 billion. It's got Bifido, which is also important. In fact, all of these have been shown to improve weight and metabolic conditions. And so 1 capsule twice a day, and then once you've normalized what you use whatever the product for, you can just go into a maintenance dose. Synbiotic, this is the one that is combination. You see, it's got a probiotic, 34 billion, with yeast, got digestive enzymes, and pre and probiotics, and prostate. This is an exciting one. I actually designed this one for me because I'm getting of age now, and soon when I hit 60, I'm going to have to bloody watch my prostate as well. So we helped design years ago the Solal one, but this one has got nettle root extract. Look at the dose, 500 milligrams, Liposomal chrysin. So don't come back and tell me this is too little. This is liposomal chrysin. Because remember, that you need volumes and volumes. There's no point in having a fantastic product and the client needs to take 48 capsules a day. Saw palmetto in a 4:1 extract, 300 milligrams. Beta-cytosterol, 130. Pingium, 4:1, 63. DIM, indole 3-carbinol, lycopene. You add berberine to potentiate that guy and that guy. And then cellulomethionine. And then more importantly, some anti-inflammatory component as well. So I'll challenge you guys. There isn't one like this world over in terms of improving prostate health. It's got basically all the big guns in one. So if this doesn't help, then you've got no choice but to go synthetic. So she claims there's hot topics this year. This is Leonie's slide. Weight loss comes next. What's new? So that's, I think, February. And if there's any issues, please speak to Leonie. That's her details. And you'll contact her for the CPD points. And that's the new list of products. Now, what isn't here is the one with the spike protein. And it's called Rescue Clear. Yeah, I think that's it. Let's go to stop sharing. Let's go to, oh, still 53 people on board. All right. So I'll tell you where I went, guys. I went to Australia and New Zealand, and for the first time in my life, and my children reckon I sound like a broken record. For the first time in my life, I saw a first world country. Really, I've been all over except South America, Russia, and China, and Japan. This was a first world country. Proper. They got small problems. Sometimes the paving is not even in the country. But otherwise, everything works. And then the exciting thing was when I was in New Zealand, I met up with a guy who owns the rights to many farms products, grass-fed cows with first day milking of colostrum. I just learned that the average cow makes between 25 and 27 liters of milk on the first day, of which I always knew this part, 98% of it is colostrum, and I'm getting access to that for our patients with autoimmune problems, with, of some people requiring polygam infusions, and then children who have not got enough breast milk, and then people with leaky gut. So basically, first milking, very good percentage of colostrum that is completely from animals that are grass-fed with no hormones and no additives. And so that's obviously exciting times. And so Jake is going to arrange for that. He's the CEO of the company. I had a very exciting meeting, a very young, dynamic guy. And yeah, I was very excited to get that sorted. So, good evening. No screen view. Okay, not as yet, not as yet. People shouting me, perfect. The screen there. Is NAC safe for patients that have one functioning kidney? Yeah. In fact, it will help renal function. So today I had a patient with microalbuminuria that's improved significantly. I mean, the numbers were 300 and something, and it's down to about 10 or 15. I forget the number. It was too late to give Leonie that file. And besides, you can see how many case studies we got today already. My floor is littered with files, all spread out. In case you guys ask me a question, I need to go and pull the file out. And so NAC is safe. As long as you're using it to improve the client's kidney function or liver function, right? Will the glucose balance be enough on its own to bring down high insulin fasting? Of course, with improving diet. Also, we don't know. So I tell people it depends on the burden of the genetic profile. So you've seen families with diabetes. Some people get diabetes by 22, and some people get diabetes by age 60. What's the difference? The diet, the exercise, but more importantly, the genetic burden. So if somebody's got a stronger genetic burden and has a severe insulin resistance, if this glucose balance is not enough, I don't know what is, because I can tell you no amount of picocetanol on its own is going to be able to overcome what this guy can give you. No amount of HCA on its own can do this. No amount of cinnamon, you need 3 grams of cinnamon. And so previously I designed glucose stabilizer that had 6 products. And remember, there's a problem with space. So this one now has much more stronger products. So yeah, if you're going to go natural, this is the one you want to try. Because most products have only 2 or 3. Glucose stabilizer is only one with 6. This one's 7, but of which 4 are completely different to any other product, and it's a good combination. Yeah, and so definitely worth a try with the 10,000 steps a day, with watching the carbs, and then if it's not enough, yeah, then you go synthetic. I've told you guys what to do. Also, the FOS in the probiotic, would that not aggravate patients that have IBS, SIBO, and FODMAP sensitivity? Yeah, so that's why you don't find that in the 250 billion. You don't find FOS in the 550 billion. It's not in the lean and it's not in the trillion. It is in another product on its own called Gut Nourish, and it's got FOS, GOS, indulin, pre-digested guar gum. It's got butyric, it's got acetic and propionic acid. All 7 fibers known to improve gut movement, to promote the survival of good bacteria, but more importantly, to help fix, butyric will help fix that lining of the gut, right? And so with all of these, like the trillion, you're not going to just tell the patient, from tomorrow, take a trillion. It's 3 capsules. Start with 1, and that's with all probiotics. You've got to tell them that they initially some patients will be sensitive to it, where there's a bit of a flap, the gut is trying to get used to it. So you start off with 1 capsule. After a week, go to 2. After week 3, if you're on a trillion, if you're on the 550 billion, do 1. After another week or 2, when you're ready, introduce a second, and so forth. So the FOS comes in the symbiotic, which is for a different set of clients, right? It's for the client who had leaky gut, no SIBO, now quite further down the line, not yet sorted on their own, and so you need a probiotic with some prebiotics and digestive enzymes. So that's the one that is in the combination, right? So there's various products for various settings. One needs to find which one you're going to need. Is that all today, guys? Where's the questions? Okay. So anybody else wants to put up the hand, ask any other question? I'm told there's 5 minutes left in your meeting. So if there's no other questions, I hope you guys have a fantastic year ahead. Lean on Leonie if you need anything. That's where you're going to get your CPD points. The other thing is, between tomorrow and the 28th of February, all 11 products are going to be coming more or less every 3 days. One's being delivered. I must tell you why there was a delay in the probiotic range. Remember, we kept telling you guys, oh, it's coming in October. Oh, no, it's coming end of November. Oh, it's coming December. And now, because the capsule was held back by Sapkra, because they said they've never had a capsule like this, so it has to be registered. Hence, these things take a while to get registered. So everything's been hanging a bit, and now everything's gung-ho, going ahead. And tomorrow, today or tomorrow, I think today, the ESMA one got delivered. And so, yeah, it's exciting times. So thanks a lot. Have a good evening. Thank you for lending me your ear. Have a fantastic year ahead, and may you and your family be blessed. Bye.